Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning. I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center. Thanks for joining us for today's episode of Bench to Bedside. With me today are Dr. Nirmal Veeramachaneni and Dr. Alykhan Nagji, thoracic surgeons who specialize in minimally invasive surgery to treat lung cancer. Thank you both for being with us this morning. Lung cancer, as you both know, is the leading cause of death for both men and women. And each year, more men and women die of lung cancer than colon, breast, prostate cancer combined. And in 2018, about 234,000 new cases of lung cancer will be diagnosed. And overall, lung cancer makes up about 14% of all new cancer diagnoses. So while these statistics are pretty sobering, if caught at a very early stage, we can often treat lung cancer patients effectively with surgery. So, Dr. Veeramachaneni, there seems to be a growing number of female non-smokers who are being diagnosed with lung cancer. And do you have an explanation for this phenomenon? And is there anything that these patients have in common as far as their clinical characteristics?
Well, you raise a really important point. One is that not everybody who gets lung cancer is a smoker. There's a lot of stigma associated with lung cancer, so patients don't talk about it. They don't talk to their primary care physician. They don't talk to their family because there's so much stigma associated with smoking and lung cancer that it's sometimes a barrier to care. Mm-hmm. Fully 20 to 30% of new cases of lung cancer are in patients who are never smokers. And you raise a good point that worldwide there's a rising incidence of women who are never smokers. Globally, epidemiologists have looked at this. There are data to suggest it might be due to cooking fuels, for instance, exposure in India or China, but that's not so true in the U.S. In the U.S., it might simply be for secondhand smoking exposure. Honestly, we don't know. But the one common characteristics of this patient population is they're often driven by single mutations. So what has changed in the last 20 years is that we have targeted molecular therapy for these patients, especially women who are never smokers who get diagnosed with lung cancer. So even at later stages, they don't behave like patients with the same stage of lung cancer if they were smokers. They are sometimes easier to treat and are more responsive to the treatment that we have. I would say in the last 10 years there are at least a dozen new drugs that have come on the market that have shown efficacy, and it's all driven by the molecular basis of their cancer.
So one of the primary reasons for this session is we really want to talk about screening. And it's such an important part of early detection, obviously. Can you tell us a little bit about the lung screening process? Who is this appropriate for? What do the patients go through?
Right. So I'm going to stress that if you meet the criteria for lung cancer screening, don't ignore it. Because for the first time in the last 100 years of smoking prevention efforts, we can say that by doing a non-invasive test, you can potentially save your life. So about 15 years ago, the National Lung Cancer Screening Study came out, and that demonstrated that in high-risk smoking patients, by going through the screening process, you can catch lung cancer at an earlier stage and decrease the risk of dying from the lung cancer. The American study that was the basis of our recommendation showed a 20% reduction in lung cancer death. 20% is huge. Now the Europeans published, or they presented their data last month, which showed that in high-risk men, there was a 40% reduction in dying from lung cancer if they went through the screening process. And that effect is probably even greater in women. In the high-risk women population, it was an almost 60% reduction in dying from lung cancer. This is huge. Wow. In 2018, the patients that we are looking to screen are those over the age of 55 who smoked at least 30 pack years. This is where the math gets a little confusing. 30 pack years means smoking a pack a day for 30 years, or 2 packs a day for 15. And also patients who have been smoking spending 15 minutes on a CT scanner without an IV or anything else for every year till well into your 70s. But it's a simple intervention, and it's enough to save your life.
Mm-hmm. What about people who have who qualify in terms of pack years but no longer smoke?
So the current evidence suggests that if you have been smoking within the last 15 years, you're still at risk for lung cancer. Mm-hmm. Smoking in general is bad for you for a number of reasons. It increases cardiovascular disease, lung disease, and other problems. So we want to capture the patients who have been smoking within the last 15 years and also smoking a lot.
Mm-hmm. So Dr. Nagji, could you walk us through what happens once a lung nodule is found? What's the next step in the process?
So fortunately here at KU, we actually have a robust team of nurse practitioners that run our lung cancer screening program. And those lung cancer screening nurses actually have a direct tie to us. And so I think that communication that we have with them is the most important thing. Once they find a nodule that seems concerning, what they'll do is they'll call our nurse navigation team. We have 2 dedicated nurse navigators for our lung cancer program. And their job is to make sure that we get all of the upfront information, we get the appropriate testing for the patient, and that they are appropriately placed in our clinics to make sure that they're seen in an appropriate amount of time. And I think that that's important, that we're getting these soon and then we're following up with them very closely. So our nurse navigation program, I would put second to none. I think that they're a very good group of people who want to make sure that we are seeing our patients and caring for them in an appropriate manner.
So, so both of you are obviously very well versed in minimally invasive surgeries for the removal of lung cancer, and you specifically, Dr. Veeramachaneni, are one of the few thoracic surgeons in the United States and Canada performing this so-called uniportal VATS, minimally invasive surgeries for lung cancer. And we're going to have you explain all of that, so it's not a big bunch of gobbledygook there. But so what are the benefits of having that expertise here at the KU Cancer Center, and why do you want to try to minimize the invasiveness of this procedure?
For the last 100 years of thoracic surgery, patients were getting fairly large incisions on their side. You'd use a rib spreader to spread the ribs apart, and it was maximally invasive. Patients typically used to be in the hospital for 7 to 10 days, if not longer, and it would be a full month to 2 months before they really recovered from the pain associated with a major incision. In the early 2000s, things were revolutionized. An Italian surgeon came up with the idea of minimally invasive lung cancer resection. Similar to how gallbladders are taken out with multiple small incisions, he was doing the same thing for lung cancer. Well, it's taken off, and unfortunately in the United States, only about 40% of lung cancer resections are still done minimally invasively. The standard minimally invasive approach, it usually involves anywhere from 2 to 4 incisions on a patient's side. And patients generally doing well. Compared to an open operation, it is head and shoulders above. The recovery is much less. We've shown that the degree of inflammation that the body experiences is less. Patients who are at high risk for an operation are better able to tolerate it. For those patients who need chemotherapy afterwards, they're better able to tolerate the chemotherapy and actually get to the chemotherapy because they're not in pain. There are different multiple modalities of dealing with minimally invasive surgery. So in a traditional thoracoscopic approach, surgeons are placing 2 to 4 incisions. With the robot, which my partner has expertise in and he'll talk about, it's essentially using multiple incisions but using robot assistance, and it has some advantages which he's going to talk about. But for a lot of lung cancer patients that I see, we've taken minimally invasive one step further. So instead of multiple incisions, it's a single incision about 2 finger breadths wide that I place right underneath where most women would put their bra straps. And what we found is with a single incision, about 2 finger breadths wide, recovery 48 hours from the hospital. So that's a real advantage.
That is a tremendous advantage. So I want to thank our audience. If you're just joining us on Bench to Bedside, we're talking with thoracic surgeons, Dr. Nirmal Veeramachaneni and Dr. Alykhan Nagji, who specialize in minimally invasive lung cancer surgery. And remember, if you have any questions, you can post them in the comments section. So Dr. Nagji, we're discussing the benefits of minimally invasive surgery. What additional options are there for patients who want to explore minimally invasive procedures, and could you tell us a little bit about those?
Sure. As my partner already described, there are traditional VATS surgery, which is video-assisted thoracoscopic, which what some patients sometimes call using the laser or camera in order to operate. That could involve anywhere from 2 to 4 small incisions. And then additionally, the uniportal approach that Dr. Veeramachaneni specializes in. And then my expertise would be in the area of robotic surgery. With robotic surgery, we make about 4 incisions that are less than a centimeter apiece. And this allows us to have 10 times magnification within the chest cavity, and allows for a lot easier, more facile dissection of lymph nodes, and to help for better staging. Additionally, the recovery is fairly similar in that patients usually go home within 48 hours. Pain is a little bit more tolerated. We are able to get patients moving closer and further to home sooner, and that's important into their recovery and to moving on with what they want to do in life. But I think the most important thing that we have to understand is that not every patient benefits from minimally invasive surgery. Not every cancer is the same. So what we do here is that we make sure that we have the appropriate intervention for the appropriate type of cancer that we're dealing with. If we can do minimally invasive, we will. If we need to do something a little bit more invasive, then that's what we'll need to do. But we're going to make sure we tailor that therapy appropriate for the patient to get the best oncologic outcome for the patient so that they can move on with life.
Okay. So it sounds like we have a pretty nice variety of different types of minimally invasive surgery, and you've touched on this a little bit, but why is that so important to have so many options available to us?
I think that each patient is different. As we look at each individual, they have different wishes, different goals in life, and I think that each individual cancer is also different. So I think that as long as we as a group provide all the treatment modalities necessary in order to help a patient, then we are providing the optimal care for that patient. I think that's a benefit that we have here at KU, in that we can provide all of those options for a patient.
So Dr. Nagji, for patients that are seeking treatment with us, our cancer center offers some real strengths, obviously, including NCI designation, the academic culture. What else, is there anything else that patients are seeking surgical treatment for lung cancer need to know about that? I
think the most important thing as a patient, you want to make sure that the physicians, the nursing staff in the hospital cares about you, and cares for you in the way that you would want to be cared for, a member of the family, if you will. And I think that that's important. Here at KU, what we have specialized nurses that are on our ICU and our floors that are dedicated to the care of lung cancer patients. When we see them in postoperative settings, we have dedicated nurse practitioners that their sole responsibility is to care for the lung cancer patient. And I think knowing that as a patient is comforting, that we will make sure that we treat you like family, and family that we like, so that we can help you move forward and have you do the things that you want to do in life.
So I want to get back to the screening question. If a patient or one of our viewers is interested in being screened, how do they access that program, and which which one of our campuses offers lung cancer screening?
So it's fairly simple. If you're already part of the KU family for primary care, just chat with your primary care physician. We have the entire program set up so with a single click of a button in our electronic medical record, it automatically activates the entire process of our navigator contacting the patient and then going from there. But if you're outside of the KU system and you still want to be taken care of here, we're happy to take care of you. Our website has the number to reach out to our navigator directly, and she will take care of it.
Okay. And the lung cancer screening involves scanning with what types of modalities?
So lung cancer screening is meant to, one, not be invasive and to minimize the amount of radiation.
Okay.
We offer this protocol of the low-dose radiation at 2 of our campuses, the main hospital here as well as in Indian Creek. Mm-hmm. Our program is set up so that patients don't have to wait for an extended period of time. We've actually timed it from the time the patient sees our nurse and gets the appropriate counseling regarding what the process entails, to then going over to getting their scan and then coming back. In under 20 minutes we can give you a report. So we've timed it. We have 3 dedicated chest radiologists who read all of our scans to ensure quality. And also we keep track of everyone. So if you need follow-up, we'll take care of it.
That sounds pretty well like a well-oiled machine there. So, well, I want to thank both of you, Dr. Veeramachaneni and Dr. Nagji. Any final thoughts for our viewers today?
The biggest thing I would stress is don't ignore this. If you're a smoker and you're over the age of 55, talk to your physician about your eligibility for lung cancer screening. Lung cancer screening efforts have been around for 40 years, but it's only with the advent of appropriate CT scans that we've actually shown that we can decrease mortality. The latest data indicate a 40% reduction in chance of dying from lung cancer if you get screened if you're a male, and perhaps up to 60% if you're a woman. So don't ignore it.
That's a huge...
to save your life.
Yeah, absolutely. Well, thanks so much for being with us today. And that's it for this morning's program. Thank you so much for joining us. For more information on minimally invasive surgical procedures to treat lung cancer, please visit kucancercenter.org. We hope you'll join us next week, Wednesday at 10 a.m. Thanks for watching.